coming up, and you should know the nuances of blood transfusion because it's a very important transfusion which is life-saving, and sometimes it can be linked to a complication which can be life-threatening also. So we'll have a discussion on this. We start with Dr. Shuttam. He is a junior resident from Barasat. Along with me today is Dr. Orkapav Rai. He is also a professor of surgery at Calcutta Medical College. He is present here physically. So we'll have this moderation by Dr. Rai today. So we'll start with the first topic. Dr. Shuttam from Barasat District Hospital is a first year junior resident. He will be presenting on blood grouping, cross matching, and blood banking. Dr. Shuttam? Dr. Ijlal. Oh, sorry. Is Dr. Ijlal, sorry. Dr. Ijlal Kadri from Howrah District Hospital will be taking the first topic. Sorry, Dr. Ijlal, please start. Share your screen. I'm the class here. I'm from the class.
Sir, I am. Am I audible to everyone?
Yes.
Yes, sir.
Good morning, sir, seniors, and my dear colleagues. Myself, Dr. Ijlal Ahmad Kadri, first year of DNB PGT from Howrah District Hospital. Today, I am going to present before you blood banking, blood grouping, and cross matching. Blood bank introduction. Blood bank is a bank of blood component which is gathered as a result of blood donation. Here it is stored, preserved for later use in blood transfusion. The blood bank, the term is typically referred to part or division of a hospital where storage of blood products occurs. It ensures the proper testing of the blood, thereby reducing the risk of transfusion-related events. It can be a government body or a private setup. History. On March 15, 1937, world's first hospital blood bank was established in Cook County Hospital of Chicago, United States. In 1939, India's first blood bank was set up in the School of Tropical Medicine, Kolkata, by Sir Upendranath B., the then chairman of Bengal Red Cross Society. In 1986, first AIDS patient due to blood transfusion in Mumbai was reported, thus realizing the immense importance of testing the blood before transfusion. In 1996, Supreme Court of India gave a judgment on blood transfusion and blood banking in India, as a result of which National Blood Transfusion Council and State Blood Council were established. Storage of blood. Most of the blood for transfusion is collected as a whole blood. Whole blood is typically separated by centrifugation into its components. Unit of whole blood and RBC are both kept refrigerated at the temperature of 1 to 6 degrees Celsius with maximum permitted storage period of 35 to 40 days respectively. This is known as short-term storage of the blood. Frozen red cells can be stored up to 1 to 2 years at a temperature of minus 65 degrees Celsius. This is known as long-term storage of the blood. Now coming to treatment of blood plasma. When the plasma is frozen and used for transfusion, it is labeled as fresh frozen plasma, that is FFP. When it is fractionated into other products, it is labeled as recovered plasma or plasma for fractionation. The layer between RBC and plasma is known as buffy coat. It is removed to make platelets for transfusion. Platelets have shelf life of 5 days when kept at room temperature, that is 20 to 25 degrees Celsius with frequent agitation. Now coming to blood grouping and cross matching. Blood grouping. It is based on the type of antigen present on the RBCs. There are almost 300 blood group systems, but from clinical point of view, ABO and RS system are important. Other blood groups includes MNS, Duffy, and Lewis. ABO system. ABO system was discovered by Landsteiner in 1900. The RBCs contains the RBC contains different antigen and plasma has antibodies. Genes which control ABO system are present on chromosome number 9. Landsteiner's law. It says if an antigen is present on the patient's RBC, the corresponding antibody should not be present in the patient's plasma under normal condition. Now coming to major ABO blood grouping. See, in the A blood group, the A blood group has A antigen, while antibody present is anti-B. Here antigen B is missing. Similarly, in a B blood group, the antigen present is B, where antigen missing is A. Blood group O doesn't have any antigen. It has antibody A and B. Blood group AB has both of the antigen present on the RBC, whereas it has missing antibody as well as other antigen. Methods of blood grouping. There are two methods of blood grouping. One is slide method and other is tube method. Tube method is it is more like better, but it takes longer time. Here the sample in the tube is kept with the antiserum and it is incubated, then centrifuged, and later it is examined microscopically and macroscopically and microscopically for agglutination. Slide method. Here we have to take 3 slides and antisera A and B and blood samples. Procedure. We have to take 2 clean slides and mark them as 1 and 2. Then we have to put 1 drop of antisera on antisera A on slide 1 and 1 drop of antisera B on slide 2. Then we have to add 1 drop of blood to each and mix well with the stick. Waiting period is 5 minutes and then we have to observe. See, we can see in the slide if any agglutination occurs, it is visible with the naked eyes as like clumps, dark reddish clumps of different sizes. And if agglutination is minimal, we can confirm it by microscope. Interpretation. Agglutination with antisera A, not with antisera B, then the blood group is labeled as group A. Similarly, agglutination with antisera B, not with antisera A, then the blood group is labeled as B. Agglutination with both antisera A and B, it is labeled as AB blood group. If no agglutination occurs in any slide, it is labeled as blood group O. The concept of universal donor and universal recipient. If the blood group O has no antigen, so no agglutination, therefore it is known as universal donor. Universal recipient AB is called as universal recipient, as it contains both A and B antigen. Bombay blood group, it is very rare. Here the H is the precursor of antigen A and B. These people lack antigen like that product H along with antigen A and B, but plasma contains anti-A and anti-B and anti-H antibody. Bombay phenotype are the individual who lack H gene. RS typing. RH blood group system is second in the significance after ABO system. The gene that controls the system is present on chromosome 1. RS typing consists of almost 50 related antigens. When the patient is having the D antigen, it is labeled as RH positive. 80% of the population are almost Rh positive. Rh negative. There is absence of D antigen. These individuals constitute about 17% of the population. There are other CC and EE antigen, but these are very weak antigen, and the risk of sensitization is less than that of D antigen. Rh antibody. Unlike ABO system, there is no natural occurring antibodies against Rh antigen in Rh negative individuals. It usually develops after exposure to Rh antigen following transfusion or pregnancy. It can be detected by enzyme treatment or home test. Significance of Rh incompatibility. It can result into hemolytic transfusion reaction, and in newborns, hemolytic disease. Importance of blood grouping and Rh typing. It is important while transfusing blood to the patient, and in newborns as a hemolytic disease of newborn, and sometimes in paternity dispute and medico-legal issues, and for as a study in immunology, genetics, and anthropology, and some diseases like peptic ulcer, blood group O is more susceptible to like this disease, and blood group A is more susceptible to gastric ulcer. Cross matching. It is also known as compatibility testing. It is the most important test after like after ABO system, or before blood transfusion is given. The primary purpose of cross matching is to detect ABO incompatibility between donor and recipient. It is carried out to prevent transfusion reactions by detecting antibodies in recipient's serum. There are the two main functions of cross matching test is to confirm ABO compatibility between donor and recipient. It may detect presence of irregular antibody in the patient's serum that will react with the donor RBC. Cross matching has two components, major and minor. In major cross matching, we have to mix the patient's plasma with donor's RBC. In minor cross matching test, we have to mix the donor's plasma with the patient RBC. Right now, it is completely eliminated in most blood banks. Recipient cells are combined with the recipient cells are combined with the donor plasma. The procedure to do compatibility test. Here we have to take 1 drop of the recipient's serum or plasma in a small test tube. Then we have to add 5% saline suspension of the donor's RBC. After mixing, we have to incubate at room temperature, then centrifuge. Then we have to check for agglutination, just like we did in ABO blood group system. Screening test before blood transfusion. We have to screen major 5 diseases, that is malaria, syphilis, hepatitis B, hepatitis C, and HIV. Thank you.
So it's a nice and elaborate presentation. 2 to 3 things I should just add on, because as far as history part, the blood banking term has been coined by one scientist of that time in Chicago hospital, name is Bernard Santos. He has coined the term and he came with all the ideas for blood banking. Number 2, one thing regarding grouping, this is just term. One is forward grouping and one is reverse grouping. Forward grouping is when you are grouping for the antigens in the RBC, it is called forward grouping. And reverse grouping, when you are grouping for the antibodies in the plasma, that is reverse grouping. Now, in the recent scenario, one thing you have missed, nowadays, HLA matching is also very important in case of blood banking, because whenever we are going to discuss about blood product transfusion and later on the complications of blood transfusions. Nowadays, there are more aims at blood products transfusion rather than whole blood transfusions. And regarding platelet transfusion, some complications are coming up. And that is mostly due to HLA incompatibility. So that part should also be included in your presentation or in blood banking and cross matching. Otherwise, it's nice.
Okay, sir.
Yes. And then you have rightly mentioned about the central and the state blood transfusion council. And you know that there are strict licensing criteria for creating a blood bank. That is one important part, that one has to have a follow the strict licensing criteria for having a blood bank. And secondly, regarding the storage, you have mentioned the temperature. But keep in mind that in most of the situations, we get blood from the blood bank and keep in our normal refrigerator. So that is not the ideal freezing system for preserving the blood. Because if you keep your normal refrigerator, that refrigerator has a compressor which becomes on and off depending on the temperature. And that vibration causes damage of the RBC. So if you go to the blood bank, you find there are a lot of refrigerators, but there is no vibration. They are all freezers. So the ideal part for preservation should be a non-vibrating refrigerator, where you maintain the temperature as you described. And regarding the blood banking, one thing you should also touch about is a collection of blood. And when you go for blood collection, there is something to be followed in a blood donation camp also, where you need to screen the donors. We have some test that is being done afterwards, but if the history wise the donor is not suitable, you should discard those donors. And then while collecting blood, there is a method of collection of blood. You insert a very wide bore, is a 14 gauge cannula that you insert, and there is a blood pressure cuff being put around the arm, and then the person is asked to pump, so that you collect the blood very rapidly. And you use some nowadays you have more preservation. Previously it was citrate, now it is acid phosphate dextrose that preserve the blood for about 7 weeks time. So otherwise you have covered very nicely. So these are all basic concepts for blood banking, storage, and how to do cross matching, and they're all important for planning blood transfusion. So we pass on to the next presenter, Dr. Shettam, who will talking on transfusion blood. Nowadays you see there is hardly you get whole blood, because nowadays the concept is you transfuse whatever is required in a particular clinical situation. Okay, if you need whole blood, you have to transfuse PRBC, plasma, and the platelets separately. So Dr. Shettam will be speaking on the blood products and their uses in clinical practice. Dr. Shettam, please share your screen. Shettam, you unmute. Shettam, can you hear us? Shettam?
Hello, am I audible?
Yes, you are audible. Share your screen. You unmute yourself, unmute. Shettam, you have to unmute. Presentation is here.
Yes, here also. If there is any problem, I'll play for you.
Shettam, share your screen. Otherwise, we have our presentation. We can share the screen from you.
Hello, sir.
Right,
Is this visible?
Yes, yes. Share your screen.
Sir, sharing.
Yes.
Dr. Satyam, your screen is not visible. Can you please share it?
Shrutam, can you hear us?
Yes, sir, I can hear.
So you are sharing screen, you can start presenting. Okay. You can see the screen,
Yes, sir.
then start. You start presentation, Dr. Alok will keep on changing the slides.
Yeah.
Yes, start.
Hello, good morning. Hello, good morning, everyone. I'm Dr. Satyam from DNB First Year Resident from North 24 Finance District Hospital. Here I am today with all of you to share my presentation on blood products. Okay, so here is this first brief introduction about the blood products. Whole blood was considered to be the standard in transfusion until late 1970s when component therapy began to gain prominence. This change in practice was made possible by the development of improved collection strategies, infectious disease screening, and advances in preservative solutions and storage. Coming to blood grouping and cross matching, as already discussed, blood grouping is done for ABO and RH antigen, while cross matching is performed between donor RBC and recipient serum. Cross matching should ideally always be performed before the use of any substitute like products like dextran interfere with the typing procedure. Now coming to indication of blood products. There are several blood products, some of which indications include volume replacement, treatment of anemia, improvement of oxygen carrying capacity, coagulation disorders, prophylactic before any major surgery is planned. Now, whole blood is a mixture of cellular element, colloids, crystalloids. As different blood components have different relative densities, segmentation, rate, size, they can be separated when a centrifugal force is applied to them. In an increasing order of specific gravity, the components are plasma more than platelets, more than WBC leukocytes, Buffy code, more than packed RBC. The components must ideally be separated within 4 hours of blood collection. If any single component is separated, the process is known as apheresis. Examples include platelet apheresis, plasma apheresis, etc. Nowadays, totally automated blood component separator instruments are used for the separation of blood products. This picture is shows a centrifuge machine which is used to separate the blood components. As we see in the bottom test tube, the RBC settle. The RBC is having the maximum specific gravity, they settle in the bottom test tube. Followed by, in the middle part, we have this Buffy coat layer which is consisting of leukocyte and platelets. Followed by, at the top, we are getting plasma layer which is having the least specific layer. This is again a pictorial description of centrifuge procedure which we are following. In the first test tube, whole blood is represented, which is followed by first centrifugation. After first centrifugation, the components separate in the bottom part, middle part, and the upper part. The bottom part consists of RBCs. The middle part, which is known as the Buffy coat layer, it consists of WBC and platelet, while the supernatant part, it is known as platelet-rich plasma. This is followed by a second cycle of centrifugation, which separates the platelet-rich plasma into platelet-poor plasma, which is the supernatant layer, which is later discarded, and the bottom precipitate, which consists of concentrated platelets and WBC. This is the same pictorial representation of taking the whole blood and separating into different components. Now coming to different blood products. First is whole blood. The volume of a whole blood bag is 350 to 450 ml. The storage temperature is 2 to 6 degrees Celsius. Shelf life will depend upon the anticoagulant used. If the anticoagulant used is acid citrate dextrose, the shelf life is 21 days. If the anticoagulant used is citrate phosphate dextrose, it is 21 days. If it is citrate phosphate dextrose again, it is 35 days. And if it is sodium adenine glucose mannitol, it is 42 days, that is maximum. Indication of whole blood. We use whole blood in case of acute hemorrhage. Disadvantage of using whole blood as a blood product is during storage there occurs a rapid depletion in ATP and 2,3 BPG layers levels, leading to an altered oxygen dissociation curve of hemoglobin, leading to decreased oxygen transport. When the whole blood is stored in the blood bank as a product, the RBCs will become progressively acidotic, leading to increased levels of lactate, potassium, and ammonia. Coming to the second blood component, that is packed RBC. Packed RBC is the bottom layer of the centrifuge. It is obtained after concentrated suspension of RBC formed by the removal of supernatant plasma after centrifugation. Due to removal of plasma, incidence of reactions due to plasma component are reduced. Also, in this case, RBC viability is higher and concentration of ATP and 2,3 BPG are maintained. The volume is similar to whole blood, that is 350 ml. The storage temperature also similar to whole blood, that is 2 to 6 degrees Celsius. And shelf life, again, it will depend upon anticoagulant use. Indication of packed RBC. We will use packed RBC in case of any volume depleted states like that of severe anemia, chronic anemia. And 1 unit of packed RBC will increase the hemoglobin level of 1 gram per deciliter. Coming to the third blood component, that is FFP plus protein plasma. It is a source of vitamin K dependent clotting factors, that is clotting factors 2, 7, 9, 10. It is the only source of factor 5. The volume of an FFP bag is 200 ml, while the storage temperature is less than minus 18 degrees Celsius. The shelf life being 1 year. Indication in case of multiple coagulation factor deficiency. In case of any liver disease where the coagulation factor production is affected. Coming to the fourth blood component, cryoprecipitate. Cryoprecipitate consists of factors factor 8, factor 13, fibrinogen, and von Willebrand factors. Therefore, it is used in conditions like factor 8 deficiency, hemophilia A, factor 13 deficiency, afibrinogenemia, and von Willebrand disease. The volume of the cryoprecipitate bag is 10 to 20 ml. The storage temperature is less than minus 18 degrees Celsius, and the shelf life. The fifth blood component is platelet concentrate. These include random donor platelet and single donor platelet. The volume of RDP is 50 to 70 ml, while the volume of SDP is 200 to 300 ml. The storage temperature for platelet products is 20 to 25 degrees Celsius. That is at room temperature with constant agitation in a platelet agitator. Shelf life is up to 5 days, that is 120 hours from the time of collection. Indication in case of thrombocytopenia due to any reason. Example, due to massive blood loss, due to massive blood replacement with platelet poor products, or in case of any qualitative or quantitative platelet disorder like Barnard-Solier syndrome, Glasman thrombocythemia, etc. Now, this platelet commodity is highly labile and high risk of contamination and transmission of infections. Transmission infection rate is highest since it is stored at room temperature. 1 unit of RDP will increase the platelet count by 10,000, while 1 unit of SDP will increase the platelet count by 30 to 50,000. Obviously, we can see that SDP is having more advantages over RDP as a platelet component. The next blood component is autologous blood. In this case, the patients can donate and store their blood preoperatively. Up to 5 units can be collected for subsequent use, provided the patient's hemoglobin is more than 11 gram% and his hematocrit is more than 34%. The first procurement can be done more than before 14 days before the planned surgery, while the last one can be done up to 3 days before the planned OT. The donations can be done at an interval of 3 to 4 days. The patients can be given recombinant human erythropoietin as it accelerates the formation of RBC. The next component is leukocyte reduced and leukocyte reduced post R. These products are obtained by filtration, which removes almost 99.9% WBC and majority of platelets. Additional saline was can be given to form this component known as leukocyte reduced post RP. Leukocyte reductions has advantages like it prevents febrile reaction, which manifests very commonly in the post-transfusion period as febrile hemolytic reaction, which manifests as fever with or without trial. This also reduces alloimmunization to HLE class 1 antigen and the risk of cytomegalovirus infection. An allogenic transfusion of WBC might be associated with post-transfusion bacterial infection and multi-organ failure. In such cases, leukocyte-reduced blood is useful to reduce the risk of infection and mortality. Coming to the last slide, that is blood substitute. These blood substitutes can be divided into red cell substitute and plasma substitute. Red cell substitute are again divided into biomimetic and abiotic substitute. Biomimetic substitute, as the name suggests, these are hemoglobin based and these mimic the standard oxygen carrying capacity of blood. These are mostly under trial. Abiotic substitute, these include, these are perfluorocarbon based, these are synthetic oxygen carriers. Coming to plasma substitute, these include human albumin 4.5%, which is obtained by plasma fractionation into cirrhosis, liver, hydroxyethyl starch. It is a plasma volume expander. Going to gelatin, which is gelatin, which is used IV as Hemaxil, commonly used as a plasma expander. And the last thing is dextrins. Dextrins are polysaccharides of variable molecular weight obtained from bacteria, leuconostoc, mesenteroids, and yeast. Dextrins interfere with blood grouping cross-matching. Dextrins can be classified into high molecular weight and low molecular weight. The disadvantage using dextrins is that in high doses it can lead to platelet dysfunction, hyperchloremic acidosis, and central pontine myelinosis. That's all about.
Okay. 2 to 3 things I should tell you that we have been told to discuss about blood products. So don't cross over like, yes, blood substitute may be a topic, but it is not included in blood products. It's a separate topic. So yes, it should be included in the topics for the completions of all the parts. Number 1. Number 2, you have told that PRBC volume should be 300 to 350 ml, as I can remember, but it should not be more than 250 ml. It should be 200 to 250 ml in general. Number 3, regarding platelet transfusion. In case of platelet transfusion, chance of infection will reduce if you use single donor platelet. And the term is you have to transfuse platelet when there is a count less than 10,000 unit without any complications. And if it is less than 50,000 with other complications, you should transfuse platelet. Number 2. Number 3, 2 to 3 things you didn't mention in cryoprecipitate. Number 1, cryoprecipitate are the most common blood product which can give infection, transmit infection. And number 2, it should be transfused within 6 hours from the delivery. So these are the things I have to operate.
Yeah, and again in the blood substitute, you have taken albumin. Albumin again is not a blood substitute. Albumin is again a part of blood component. It is available either as 5% or 20%. So albumin is not a blood substitute. It's one of the component of blood being transfused for specific purpose. Okay. Otherwise, you have gone through all the components that you use in clinical practice and their indications. And I think Anurag will take the transfusion part.
Transfusion.
Complications. Yeah. And transfusion also, or
The transfusion and complications.
okay. So we pass on to the last speaker, Dr. Anurag Majid, who is a junior resident first year at SSKM Hospital, IPGMR. Anurag, you can share your screen.
Yes, sir.
take sometimes from any of the screens in Wi-Fi connection.
Sir. Good morning, sir.
Yes, yes.
Oh, I thought.
Let's start.
Good morning, sir.
Go to share. Yes, share your screen.
Good morning, sir.
Yes.
Good morning, everyone. Am I able to share my screen? Is it visible?
No, not yet.
Okay, sir. I'll check. Sir, I've already shared my screen.
Yes, yes, it's coming up.
Okay, sir. Sir, I'll start then, sir.
Yes, yes, start. It's visible.
Good morning. Good morning, sir. Good morning, everyone. I am Anuradha Maji from SSKMH in the Department of General Surgery, and my topic is complications of blood transfusion. Blood transfusion reactions can be grouped into two types, which can be non-immune mediated reactions and immune mediated reactions. The non-immune mediated reactions can be due to fluid overload, which leads to transfusion associated circulatory overload. And it can also lead to hypothermia, which is due to the transfusing very cold blood or blood components. It can also lead to electrolyte toxicity in the form of hyperkalemia due to lysis of RBCs, which lead to increased potassium levels in the blood bank. It can lead to hypocalcemia due to circulation of calcium because the anticoagulant has citrate. Iron overload can occur due to multiple transfusions, and infections can occur. I'll be explaining them henceforth. Sir, first we'll come to transfusion-associated circulatory overload, where the flow rate of the transfusion is more important than the volume. A person who is more prone for congestive cardiac failure, even a rapid transfusion of just 500 ml of blood can cause congestive cardiac failure, rather than if it's transfused rapidly than the whole volume. Presentations can be cardiac failure. Apart from that, renal and pulmonary pathologies in the form of dyspnea, orthopnea, cough, raised JVP. Chest X-ray will show bilateral diffuse pulmonary infiltrates. If BNP and NT-pro-BNPs are investigated, they will be elevated. Circulatory overload will be managed with restricting the IV fluids, decreasing the amount of blood components being transfused, keeping the patient propped up position, giving oxygen support, and giving diuretic to increase the urine output. With increased transfusion rate and volume, then it can massive blood transfusion. Often there is need for massive blood transfusion where TECO can occur. Massive blood transfusion by definition is replacement of the blood volume of the patient with which the patient presents within 1 hour or more than 10 PRBCs in 24 hours. It can lead to citrate toxicity and calcium chelation, leading to hypocalcemia and in the form of Chostek sign or Trousseau syndrome. And it can lead to thrombocytopenia, clotting factor deficiency, acute lung injury. Often the electrolyte imbalance and the fluid and electrolyte disbalance can be managed with transfusion of blood in the form of PRBC is to FFP is to platelet at the ratio of 1:1:1, and frequent half-hourly ABG monitoring and certain blood parameters and their correction. Apart from that, uh, we can also have transfusion related sepsis, which comes under infections. I'll be explaining them more. Iron overload, usually it will occur in hemoglobinopathies occurs due to chronic blood transfusions, because each unit of PRBC is having some 200 to 250 milligram of iron. So that will cause iron accumulation, and it will lead to endocrine, hepatic, and cardiac dysfunction, and which will usually be seen with after 100 units of RBC transfusion, PRBC transfusion. And usually iron overload will be managed with iron chelation therapy in the form of deferoxamine or deferasirox. Erythropoietin therapy can also reduce the need for blood transfusion and subsequently decrease the iron overload. Infections, the incidence of infections has drastically reduced due to screening. Viral infections like HCV, HIV, HBV can occur, CMV can occur. HCV infection, which can be acquired, the current risk being 1 in 1 million units. HIV also, the current risk being 1 in 1 million units. HBV can occur, has a greater risk of transmission than HCV. But due to vaccination, it provides protection, and like after infection, the symptoms or the progression of disease is reduced, and vaccination is protective when the titer of anti-HBs antigen antibody is more than 10 nanogram per ml. Cytomegalovirus infection can be transmitted by infected WBCs, which are found in the PRBCs or the platelets. And at risk patients are immunocompromised, neonates, transplant recipients. And that's why these patients should be given leukodepleted components. Bacterial contaminants can be present usually in PRBC and FFP, where they are refrigerated at 4 degrees C, or if they're in freezer at -20 degrees C, the likely organisms may not be the usual commensals. Rather, those which can grow at the cold temperature, which can be Pseudomonas or Escherichia, Yersinia, Acinetobacter, or Serratia. The platelet concentrates, which are more or less kept at room temperature, they will have higher chance of skin commensals and gram-positive bacteria like coagulase negative Staphylococcus. Clinical features, usually they will present with fever, chills, septic shock, DIC, which are more sudden and fulminant than the febrile non-hemolytic transfusion reactions. And the management is, you have to stop transfusion immediately, and blood components and blood samples should be sent for culture sensitivity, and broad spectrum antibiotic coverage should be given. Apart from bacterial and viral infections, there can be parasitic infections like malaria, babesiosis, Chagas disease. Apart from that, rarely dengue and Zika virus has been seen to be transmitted through blood transfusion. Prion diseases like Creutzfeldt-Jakob disease can also get transmitted through blood transfusion, and anaplasma species also. Immune-mediated, I'm coming to immune-mediated reactions, which can be allergic reactions in the form of urticaria, anaphylactic reactions, febrile non-hemolytic transfusion reactions, acute hemolytic transfusion reactions, which occur usually due to ABO incompatibility, delayed hemolytic and serologic transfusion reactions, transfusion-related acute lung injury, post-transfusion purpura. Allergic reactions occur usually due to the plasma proteins which are present in the transfused component. And if we temporarily, it is usually managed by temporarily stopping the transfusion and providing antihistaminics like diphenhydramine 50 mg. If the transfusion can be continued if the allergic reaction subsided, and the signs and symptoms, clinical features like itching or wheal, if they reduce. And often patients who are more prone to allergic reactions after transfusions, they can be pre-medicated with antihistamines. Anaphylactic reaction, usually it takes only few ml of blood component, following which anaphylactic reaction occurs in the form of dyspnea, breathlessness, coughing, nausea, vomiting, hypotension, bronchospasm, shock, respiratory arrest. It is managed with usually epinephrine, 0.5 to 1 ml at a dilution of 1:1000, given subcutaneously. In severe cases, glucocorticoids can be used. Anaphylactic reaction is rare and usually it is seen in patients who have severe IgA deficiency. These patients usually require should receive IgA deficient plasma. Acute hemolytic transfusion reaction this occurs due to ABO incompatibility. The recipients, they usually have preformed antibodies that lyse the donor RBCs. So anti-A and anti-B are responsible for majority of these reactions. After lysis of the RBCs, it releases the inflammatory mediators and cytokines, which lead to fever, chills and rigors, hypotension, renal failure, DIC, and abdominal back or flank pain. Mortality of acute hemolytic transfusion reaction is 2%. Management includes stopping the transfusion immediately, and we have to report the blood bag and the reaction to the blood bank. And apart from that, pre and post transfusion samples should be taken for establishing the hemolysis in the form of peripheral, which can be seen in peripheral blood smear, repeat typing, direct home test, repeat cross matching. And apart from that, management also includes oxygen support, diuresis with IV fluids, furosemide, mannitol, input-out monitoring, and vitals monitoring. Febrile non-hemolytic transfusion reactions, these are one of the most common transfusion reactions. They lead to increase, by definition, it is that increase in temperature of 1 degree C more during up to 4 hours of transfusion. It is usually, fever is usually associated with some nausea, vomiting, and symptoms of these most likely occur due to following platelet transfusion because of the WBC components. The WBC is leukocytes which are present within the platelets. So leukoreduction can actually reduce the febrile non-hemolytic reactions. Transfusion should be discontinued, and antipyretic should be given as supportive management. And the next reaction which we know which is very commonly seen is transfusion related acute lung injury. It is a symptom of acute hypoxia which occurs due to non-cardiogenic pulmonary edema. This occurs when donor plasma contains high titer of anti-HLA class 2 antibodies that bind to the recipient WBCs. These WBCs, they aggregate in the pulmonary vasculature and then they lyse and release mediate pulmonary vasculature, and this leads to pulmonary edema. This usually occurs within 6 hours of transfusion. It has a two-hit hypothesis, which means that initially, in more susceptible individuals, the endothelium of the pulmonary vasculature is already primed. Prime neutrophils are already present. The second hit occurs when the mediators in the transfused components activate the prime neutrophils and cause the final endothelial injury. More prevalent acute lung injury occurs in patients with mechanical ventilation, sepsis, chronic alcoholism, severe liver disease, hematologic malignancies, where positive pressure ventilation is given more than 30 centimeter of water pressure balance is being given. And implicated donors who have these high titers of anti-HLA class 2 antibodies are from multiparous women. Trally presents with sudden dyspnea, hypotension, fever, rails on auscultation, and chest X-ray shows bilateral diffuse patchy pulmonary densities. Management of Trally is supportive, largely in the form of oxygen, vasopressor, propped up position, but diuretics are not very helpful, unlike in TACO. Glucocorticoids are helpful, which decreases the pulmonary edema drastically. And pooled plasma prevents Trally because pooled plasma has a decreased level of antibody titer. Delayed transfusion reactions. They usually do not manifest within few hours of transfusion. And when these occurs, usually when previously immunized patients receive red cells with antibodies, which are in low titer. So these the hemolysis which occurs due to attacking of the RBCs are largely extravascular, but they can also occur intravascular. And usually it is seen when kid blood system antibodies are present, which lead to rapid hemolysis, relatively rapid hemolysis, which lead to these transfusion reactions. It is diagnosed by failure of increase in hemoglobin to around 1 gram per dl with 1 unit of PRBC, and associated with an unexplained fever. Alloimmunization is it can occur due to multiple blood transfusions. It can occur when there are minor blood RBC antigens, usually most commonly D, C, E, KL, Duffy, these antigens. They cause formation of alloantibodies. During cross-matching, this antibodies, they prevent, while like during cross-matching, it will always cross-react, and it becomes very difficult to find the compatible products for transfusion. So they are usually detected during pre-transfusion testing. Due to alloimmunization, the women who get alloimmunized, they have higher risk of hemolytic disease of the newborn when in pregnancy. And alloimmunization to RBCs can cause RBC lysis. Alloimmunization to platelets will lead to refractoriness of platelet transfusion. The platelet count will always be low in spite of multiple transfusions. This can also be reduced with gluco-reduced blood components, because the RBCs are low, so the formation of antibodies actually decreases. WBCs are low, so it decreases. These are the minor blood groups against which antibodies can form. This is a table from Harrison where it shows that risk of transfusion complications, their frequency has been seen. In allosensitization, RBC sensitization and HLE sensitization is very frequent compared to any other blood transfusion reactions. Is reduced. So how do we prevent? How do we prevent the transfusion reactions? Pre-transfusion testing is very important, which consists of typing, screening, and cross-matching. Typing is ABO and RH phenotyping, which is done by anti-sera of A, B, and D antigens. Screening is done by mixing the patient's serum with type O RBCs, which contain the major antigens of all the blood group system, and cross-matching is done by adding the recipient's blood plasma to donor RBCs. And before cross-matching, it should be ABO compatible. Apart from that, to prevent the need for transfusion as a whole, or to reduce the complications of transfusion, patients can be given oral iron therapy prior, usually when there is need for blood transfusions prior to surgery. Electively, oral iron therapy can be started, which will increase their iron reserve and hemoglobin values. Apart from that, injectable iron therapy can be used, but then it has higher risk of anaphylactic reaction. And autologous blood transfusion can also be given, which I'll be discussing. It has a high cost benefit ratio. Recombinant erythropoietin can also be given, and in some cases GCSF or GMCSF. Autologous transfusion is when the patient's own blood is used for transfusion. It can be in the form of, it can be of three types: pre-deposit, pre-operative hemodilution, and blood salvage. Pre-deposit is when around maximum of 5 units of blood is donated over 2 to 3 weeks before elective surgery, and during elective surgery that blood is used. Pre-operative hemodilution is where when it is expected that there is going to be 1 to 2 units of blood loss, prior removal before the procedure, and it is retransfused during the procedure. Blood salvage is when lost blood during surgery is collected, mixed with anticoagulant, washed and reinfused, which is done in a sophisticated setup and also can be done only in clean surgeries. Apart from that, there's something called patient blood management, which is adopted by WHO. It includes ways to reduce the blood transfusion and the requirement of it by maintaining some, and the complications, by maintaining some hospital-based guidelines for use of blood components, early assessment and correction of preoperative anemia with oral iron therapy 28 days before surgery, and techniques to minimize the perioperative blood loss so that the final requirement of blood actually reduces. So thank you, sir. This was my presentation of the components and how to manage them safely.
Thank you. It was an elaborate presentation, but I would like to highlight on some issues. First of all, you did not take up the blood transfusion part properly. So, what are the indications of blood transfusion? There are very three specific indications for whole blood or blood transfusions when you are going to for blood transfusion. That is number one, acute hemorrhage requiring when there is more than 20% of blood loss. Number two, hemoglobin level less than 8% without any risk factors. Number three, hemoglobin level less than 10% when there is a risk factors or any elective surgery you are going to perform. These are the three things. Number two, what are the types of blood transfusions? Number one is allogenous blood transfusion, which is commonly done. Number two, autologous blood transfusion, and number three, exchange blood transfusion, which is not done very rarely nowadays. In case autologous transfusion, there is a part what she had mentioned, that salvage. Salvage type is used nowadays in case of transplant operations, mainly liver transplant. 40 to 50 units of different blood products are needed. In that case, these salvage process is taken up. Next, regarding the another one thing, you have to mention what is emergency blood transfusions, where O negative blood group can be transfused. So these are the types of blood transfusion, indication of blood transfusion, and apart from that, indication of blood product transfusion that has already been dealt. Next, regarding complications. Now, one thing I am telling you, this question will come as a long question to you. So you have to frame the answer. So you can write like this: infectious complications, non-infectious complications. Among non-infectious complications, there is allergic and non-allergic. In non-allergies, there are acute and delayed complications. So all the part has been dealt with a manner, but not in divided mode. So first all, 2 to 3 things. This is one she had mentioned, trolley. That usually occurs within 2 hours, but can occur up to 6 hours. That is good. But all the things. Number 2, what is acute hemolytic reactions? So from surgeon's perspective, if a patient is on operating table, how will you think? How will you note? If there is excessive bleeding from the operative site, or there is bleeding from the mucous membranes, and you are seeing that there is a blood being transfused during operation, you can think of acute hemolytic reaction. So that is one. Next one, common what I have telling about the HLA plasma graft versus host reaction is also encountered in case of blood transfusion. That is, if T cell competent blood is transferred in a immunocompromised patients, that can occur. And regarding allogenic reaction and post transfusion perturbation, I think just mention one line, but these are the platelet transfusion related complications. In case of allogenic reaction, that is what happens when repeated platelet transfusion is needed. In case of, again, HLA group 1 incompatibility occurs. So here you have to give HLA matched single donor platelet transfusion, and in post transfusion program mostly occurs in, again, repeated platelet requirements and also in multipara women. Just to be remembered. And usually these two things are self-limiting, but in case of post transfusion program, sometimes you may need to transfuse IV immunoglobulin or plasmapheresis. So that I can conclude. And one thing I am saying, that for this part, if you want to go through a book and you have to write answer, you go through Washington Manual of Surgery. This is very nicely written, this whole topic.
So in surgical practice, what Dr. Rai was emphasizing, that we have to keep in mind the situations where a surgical patient needs transfusion. One is pre-op settings, second is intra-op settings, and third is the post-op setting. In pre-op setting, you are either having a acute emergency, having a patient presenting with a trauma, and second is patient is coming for elective surgery. So in trauma now, there is a concept of resuscitating the patient by giving blood transfusion instead of giving a lot of crystalloids. So this is a concept coming up where people have shown that if you keep on giving more of crystalloids, the outcome is not good. And in that case, you manage this blood loss by giving blood component in the form of 1:1:1 of PRBC, platelets, and the plasma. Second is in the elective setting. Most of our patients who are admitted for surgery are either malignant patients or surgery which are emergent. In that case, a oral or intravenous iron therapy is not a good option. In that case, you have to consider for giving the patient blood transfusion. But again, there are some criteria. What Dr. Rai said, it's not that you have to achieve 10% hemoglobin before embark for surgery. A hemoglobin up to 7 or 8 is acceptable that you can take up for elective surgery. But again, you have to keep in mind the predicted blood loss intra-op. So you have to keep adequate blood in hand so that if there is a blood loss, you have to give it. That is the pre-op setting. Intra-op, when you operate, you have blood loss, sometimes unexpected blood loss. So this blood loss has to be replaced ideally. Ideally, the intra blood loss has to revive the blood. But if the blood loss is less than 15% of your total blood volume, you can manage with crystalloids. And if you're giving crystalloids, then there is a ratio of 1:3 as a ratio between the blood and crystalloid ratio. Next is post-op setting. In the post-op setting, the important aspect for considering blood transfusion is you do a proper assessment of the patient. There are two settings. Either this patient is having anemia in the post-op period and patient has features of continuing bleed, or patient does not have continuing bleed, patient has just anemia. The management is different. If the patient has got anemia only and there is no evidence of continuing bleed, there is no haste in transfusing a lot amount of blood. If the patient hematocrit is around 30% and hemoglobin is more than 7 or 8, a blood transfusion is not essential. But if the patient has got evidence of bleed, then again the question of blood transfusion comes, and also some measures to control that blood is important. So there are the three different scenarios which are important in surgical practice for considering blood transfusion. Okay, you can take question from the audience and Comments from Dr. Maiti? Dr. Maiti, any comment?
Yes, the excellent discussion was made during this seminar. One point I'd like to make that the blood requisition that is one of the important aspect which the doctors should remember, because excess requisition sometimes causes too much loss of blood banks. So we have seen that if the requirement is less, if the requisition is made more, sometimes there is the wastage of blood products and the blood itself. And so alternative is reservation of the blood in the blood bank. So if your requirement is less, you do the less number of blood unit requisition, and sometimes you ask the blood bank to keep the blood in reserve in the blood bank so that the wastage can be prevented. That is a point. And another point I like to mention, that in case of allergic reaction or anaphylactic reaction, the speaker have mentioned about the antihistaminics, but role of steroids is also probably it was not mentioned, it is to be also mentioned. The steroid also play an important role during these reactions.
There is a question in the chat box. I hope you got the answer. For FFP transfusion, the grouping is must, because FFP contains the antibodies. But for platelet, we did not do the cross-matching, because you have a group of platelet which is from random donor platelets, which is from multiple donors. So it did not have a definite cross-matching for platelet transfusion, but plasma, yes, like PRBC.
Yes, so one thing is written in the book that grouping and cross-matching in all the blood products are not mandatory but desirable.
COVID-19 test? No. Dr. Acharya, any comment?
Yeah. As Professor Maiti has stressed, that every doctor should take precautions that no blood is wasted. And I want to add one thing to his comment, that whenever possible, we need blood for mainly two reasons. One, to increase the oxygen capacity and the volume, and certain other components are required at times for specific indications. So whenever possible, ask for components, either packed cell or component, or if the only volume is the concern, try to increase by some other means, because blood cannot be manufactured. It comes from a human body, and whole blood indications of whole blood transfusion, it has come down to a very great extent nowadays. So whenever possible, component therapy is indicated. Don't waste whole blood. That is the point I want to stress.
Yes, it's very right. Because you see that now, if you requisition for whole blood, no blood bank will supply you the whole blood now.
Yeah.
So the concept is you have to decide why you are concerning for transfusion, such as in acute setting. When you are trauma patient, we already talked that in trauma patient, a patient is losing whole blood. So in that case, the transfusion will be you transfuse 1:1:1 of PRBC, plasma, and the platelets. So you can give the whole blood, but that should be in components. And most of the situations where you need to have a requirement for blood, you should decide why you are requesting the blood, and you have to decide on the components required. Any other comments from any other student?
Another point I want to stress, Dr. Mafun,
Yes.
that is, in earlier years, autologous blood transfusion in a planned surgery was advised to patients who have a rare blood group. But I think it is time to stress on the patients who is going to undergo a planned surgery, which may be requiring blood transfusion. Just try to impress that his own blood will be given if he gives planfully beforehand, before operations, his own blood. So in that way, the requirement of blood can be minimized. I'm not minimized, can be made by his own, blood transfusion, if it is done planfully before operation. That is one thing I want to stress. Even
Dr. Prasad, any
in
comment?
ordinary common blood groups.
Hello.
Yeah, Dr. Prasad.
Mahanda,
Yes.
I want to stress one thing. is the operation can be is on two settings. One is emergency setting, patient is coming and we are bound to operate. And one
I'm
is
talking
elective
about
setting.
planned operations.
In planned operations, we see the patient and we take 1 to 2 weeks time for preparation, investigation, and from the very onset, we should start iron capsule so that in 10 days time, if the patient takes iron capsule, the hemoglobin will increase. So in a patient like cancer patient, when we are doing investigation thing, all patients should be put on iron capsule from the first visit so that the blood transfusion requirement can be reduced. Other discussion is fantastic. Thank you. Everybody has participated well. But my suggestion is, if we see an elective patient, we should start iron capsule if we anticipate some blood loss. And it should start from the.
Okay. Another thing for our speakers, most of the speaker has slides which are having too much of sentences and lines. So I suggest that when you present, make some important points in bullet form, and you describe or elaborate on that point. Don't write a slide having 4, 5, 6 lines in a paragraph, and don't make the slide very busy. Ideally, each slide should contain 6 to 8 lines, and that too, don't make a paragraph. You make a paragraph, you read, that does not make very interesting presentation. So for the speakers, I would suggest that you make salient points, write that in bullet form, and then keep on elaborating on that. Okay. So
this is a good discussion, Masanda. They are making the slide very busy. They should memorize it. They should memorize it and make slide very simple and only salient points in the slide.
Salient points. Yes.
Another point, Professor Saha, I like to mention also timing of transfusion, particularly in the trauma cases. Suppose a patient is placed for operation and there was anemia, significant anemia because of blood loss. So, and blood requisition has been done. So at that moment, blood transfusion may not be needed. It should be kept because after the control of bleeding from the site of bleeding, for example, in spreading injury, then transfusion is to be given in proper time. So unnecessarily transfusion, if made in an improper time, so that requisition blood may not be properly used. So that should be also be kept in mind at what time blood should be transfused.
Thank you very much. We finished up today. We will meet on Saturday. Saturday is probably a government holiday, but we will have the class in the morning. Okay. So Saturday will be our ward round and prediction.
Thank you. Thank you. Thank you.
Thank you so much. Thank you.
Hello.